Good afternoon, everyone. Thank you for joining us. This is the Institute of Medicine of Chicago. Today's webinar is addressing the health needs of the justice-involved individuals during reentry. We are proud to have with us today and honored Dr. Wendy Wills El-Kamin, who is the Associate Dean at Southern Illinois University School of Medicine. She's also Professor of Family and Community Medicine. So my name is Deborah Hodges. I'm the Association and Program Manager with IOMC. I've been with the organization since 2019 and very happy to be a small part of the organization in today's presentation. So today's agenda, we're going to go over a couple of items just to get you familiar with what's going to happen today. I wanted to give you some information about IOMC. We're going to talk a little bit about upcoming programs. Dr. El-Kamin will go ahead and give her presentation, and then we'll have questions and answer period, which will be at the end of her presentation itself. And there'll be a chat box and a Q&A box for you to put in your questions that you would like us to address today. So let's tell a little bit about IOMC, especially if this is the first time that you're joining the organization and on a webinar. So the Institute of Medicine was founded in 1915. It's an independent, nonprofit organization. It has distinguished leaders in the health field who collaborate to improve the health of the public. It draws upon the experience and the diverse membership of our regional leaders in the Chicago and state of Illinois area, and it addresses critical issues using interdisciplinary approaches that include education, research, trusted information, and also community engagement. It is a 501c nonprofit organization. Our membership consists of fellows. The fellows are comprised of clinicians, doctors, dentists, pharmacists, nurses, lawyers, policymakers, advocates, hospital leaders, industry leaders, and other executives. All of us together try to drive meaningful change and to bring about the better health of the public itself. If you're interested in becoming a fellow, which is open to all, please consider visiting our website, which is www.iomc.org. Click on the membership tab, or you can use the QR code that you're seeing on the right-hand side of the screen and go to the website page for that. It has the information on the membership, and it also has a nomination form or application in order to consider becoming a fellow. Keep in mind that when you do apply to become a fellow, the process is about 8 to 12 weeks. So, plan accordingly, especially if you're planning on attending any event or that's coming up in the future. We have a couple of events that are coming up that we wanted to raise awareness with you today. On April 21st, let me just move this over here. On April 21st at noon, Dr. Jennifer Sokolsky will be presenting a webinar on From Awareness to Action on Increasing HPV Vaccine Referrals in the Dental Settings. Everyone is welcome. It's open to all. Also, on June 25th of this year, we're proud to host again our 2026 Leadership Awards and annual meeting. This is one of the major fundraising events of IOMC for the year. We're proud that Dr. Aaron Sousa is going to be the keynote speaker. He is the new president of Rosalind Franklin University of Medicine and Science. That evening, it begins at 5 o'clock in the afternoon. It concludes at about 8 o'clock in the evening. That in addition to the keynote speaker, it includes introducing the new Board of Governors and, of course, thanking the past Board of Governors for all of their commitment and efforts. The Leadership Award recipients will also receive their awards. There's ample networking. There's also lively spirits and dinner. So prior to the Leadership Awards itself, and what is open right now, is the nomination process in order to nominate leaders for the awards. There are 7 categories. We hope that you will consider nominating a colleague for one of the awards itself. There's a QR code here that you can look at and in order to go to that specific page. But then again, you can just visit www.iomc.org. So right now, I'm proud to introduce Dr. El-Kamin. Oh, before that, I don't want to miss the fact that we have a career job center on the website. It has over 5,000 jobs interested. So if you're looking into a future opportunity for yourself, you can do a confidential search by setting up a page on that Career Job Center. You do not need to be a member of IOMC in order to utilize the benefits and the opportunities that are available on that web page. So at this point in time, I'm not going to go over her bio, which is fabulous, and you're going to find that out during her presentation today. Please go back to our website. You can look at the event page. Again, she has a very robust presentation today, so we're going to get into that right at this point in time. So Dr. El Amin, I'm going to turn this presentation over to you at this point in time.
Thank you, Deborah. Are you able to see my slides?
We can, just, yes, we can.
Wonderful. So first of all, I'd like to thank the Institute of Medicine in Chicago for giving me this opportunity to address a topic that I think can be transformational if we're able to put the resources and bring all of the minds together. The topic of my presentation is a public health opportunity addressing the health needs of justice-involved people during reentry. So one of the things that I wanted to start off with is really talking about the opportunities that exist for us when we are working with justice-impacted individuals. There's an opportunity for us to advance patient care, to challenge assumptions, to look at the innovation in curricula, also for us to be more transparent with the data that's available. I think for us to really improve the health of justice impacted people, we need to continue to think outside of the box and make sure that we're data driven and that we're exploring new partnerships. Dr. Lila Watson stated that if you have come to help me, you are wasting your time. But if you have come because your liberation is bound up with mine, then let us work together. I think that this quote really gives us an opportunity to think about how individuals that are justice impacted are part of our community. And the more we're able to support their reentry into society, it's an opportunity for us to improve the health of our entire community. I'd like to look at work by Dr. Shokoff, who is a pediatrician who talks about the eco-biodevelopmental framework. And this allows us to expand our focus, looking at the environmental factors of individuals that are going through reentry, which includes employment opportunities, housing stability, their ability to access healthcare, also the social factors that exist, which are extremely important when we're thinking about family support, peer influence, the community and the resiliency of the community. Cultural factors play a role, whether or not this is a intergenerational challenge that communities are experiencing. And then also the stigma, which is sometimes a barrier for individuals to be able to be successful in the reentry process. When we look at the policy and the systemic factors, policy is critical because it really does create another lens on the issues and the problems, and it can improve access. I think it's important for us to take a little bit of time and think about the humane language. The Advancing Health Equity document that was produced by the AMA and also the American Academy of Medical Colleges came out with this document in 2022, and it's a guide on language, narrative, and concepts that provide guidance to promote a deeper understanding of equity focus. When you think about the language that has surrounded individuals that have been impacted, justice impacted, there have been terms that have been used such as offender, felon, prisoner, inmate, convict. And I think it's critical for us to really shift the language so that it's person-centered. It is respecting the person's humanity. So some of the language that we are shifting to is to talk about formerly incarcerated, returning citizens, justice-involved individuals, and also ex-offenders or individuals with criminal records. As far as the reentry process is concerned, some of the words that we are seeing in the literature and they're being utilized in the community are reintegration, return to community, transition planning, reentry programs, post-release services, successful reentry, and also rehabilitation. I think that language is important because this is an element that helps build trust in the community. And there's a great book called The Thin Book of Trust, and it talks about how people trust you when they feel that you're being sincere, that you're reliable, that you're competent, and that also that you show that you care. So language is a way that we can show that we care and can really break down some of the barriers that exist for people to come in to receive health care. I also want us to keep in mind that the family and the community are profoundly impacted by any person's incarceration. This was a piece of art that was from Stanford University when they worked in medical humanities that demonstrated the fragmentation that occurs sometimes when a child has a parent that has been incarcerated. The National Academies of Sciences, Engineering, and Medicine talks about whenever we're trying to look at social risk and social needs for patients, families, and communities, we should focus on the 5 A's, and that's building awareness, adjusting some of the clinical care to accommodate some of the special needs that individuals have. We need to be providing assistance to patients that take a look at the social care and the resources, and making sure that our investment is in alignment with the person's needs and focusing on advocacy. So my entry into activism around correctional medicine started about 30 years ago. I walked into a patient's room when I was an intern, and I was on my OBGYN rotation, and my patient was actually shackled. And that was the first time that I became proximate to the lived experience of those that have been incarcerated. And I really started on a process of understanding how we can improve the care. One of the things that Brian Stevenson says is that proximity is truly a catalyst for change. And when we're not proximate, it's hard for us to have a deeper understanding of the lived experience. And when you think about those that are incarcerated, it's challenging because it is a true barrier to be able to enter into the prisons. There have been a lot of opportunities and initiatives that have tried to increase individuals coming into the prisons and the jails to truly understand what the environment looks like, how people are impacted. And that's something that I would encourage. Policymakers can have an opportunity to go inside of the prisons. Obama was one of the first presidents that ever went inside of a federal prison. And I think it creates a new lens for us to be able to develop more solutions. So I encourage everybody to become more proximate, because when you think about it, in correctional medicine, education is very limited. There's a lot of gaps in medical education. At SIU School of Medicine, we provide elective courses, and this is one avenue where medical students can get exposure to correctional medicine, but only about 10 to 20% of medical schools have a curriculum around correctional medicine and supporting individuals that have been incarcerated. There are internships, fellowships, but there really is a lack of standardization of this curriculum, and also looking at developing tools for advocacy. So I think that this is an area that we can truly improve upon. When we think about data, it's important for us to not just look at the quantitative data, but also to look at the qualitative data and to be able to hear the stories of what people are experiencing when they are incarcerated, prior to incarceration, and even during their reentry. So I encourage you all to listen to podcasts if you don't have the opportunity to become proximate to someone who has had this experience. In 1990, Chicago started looking at the life expectancy of individuals. And this was one of the first times where people started to disaggregate the data based upon neighborhoods, disaggregate the data based upon zip codes and race. And I think this is important for us to use this same type of process when we're looking at the data of individuals who have been justice impacted. When we think about the United States, we actually are the highest in the world in who is incarcerated. 1 out of 5 individuals that are justice involved in the world are incarcerated in the United States. That's about 2.3 million. When we think about that, there is a phenomenon that I think that we are experiencing in the United States that we need to come up with new solutions. And I encourage you all, one of the places that has one of the least amount of individuals that are incarcerated and have lowest rates of recidivism is actually Norway. We'll talk about that a little bit more. When we think about comparing Illinois residents and the incarcerated population, it is something that you realize it is actually racialized in many ways. So, for example, for white individuals, residents, it's about 60%. But when you look at who is incarcerated, it's only 31% inside of the prisons. But when you look at Black and African American individuals, we only make up about 14% of Illinois. However, you see that there's a 53% and 51% that are living in the prisons and in the jails. So when we think about Illinois residents and who is locked up, I think it's important for us to look at the entire ecosystem. There's only about 28,000 that are in the state prisons, but one area that we need to pay more attention to is really in the local jails, which is about 17,000. We have about 6,000 in the federal prisons. And when we look at youth, it ranges between 830 and 1,200 in different places. So when you think about the legal system, we have even more that are impacted by the justice system. We have 85,000 individuals that are presently on probation. In parole, there's about 21,000 in the state prisons and the local jails. This makes up a smaller number, and it's important for us to think about that because the healthcare is impacted when we think about probation and parole. When we think about Illinois statistics, I want us to look at the average length of stay of individuals about 2.5 to 3 years. So 1 out of 1,200 individuals each year are incarcerated in the state of Illinois. And when you think about it, it's only 0.08% of the adult population. However, when you look at disaggregating that, it has profound impacts on communities. So this is from the Prison Policy Initiative, and the Prison Policy Initiative provides information that shows of individuals that are incarcerated and have an immediate family member. It's about 42.5% that are white, but 62.9% that are Black. When we think about incarceration of extended family members, 32% white, 52.6% Black. And then also family members incarcerated for more than 10 years. It's important for us to look at the data around sentencing. For whites, it's 1.4%, but for Blacks, it's 11.9%. So looking at zip codes when we disaggregate data is important. Looking at the income levels, the education levels of zip code, neighborhood characteristics, housing conditions, access to healthcare, and the employment rates. This allows us to look at where are individuals being re-entered into and in what communities. And I wanted to bring this up because in Chicago, there are 5 zip codes that have higher numbers of individuals that are going in through the reentry process. And this allows us to be very specific about where we're placing the resources, how we can practice more place-based medicine. So in 608, there are 1,570 justice-involved people, 607, 923, 628, 785, 779 for 624. And this really impacts the entire community, but that individual is really trying to navigate getting to the top of the Maslow hierarchy. And we understand that if you don't have those physiological needs met, safety is not there, the social needs are not being met, it's very hard for someone to get to a place where they're self-actualized. And that's why it's important that we're bringing together all of the individuals in the different industries to provide support for these individuals so that they have not just their physiological needs met, but the social needs of having housing. We saw an increase rate of individuals being incarcerated over the years, especially around the 1990s, you started to see this uptick. And we call this trans-institutionalization. And trans-institutionalization is actually criminalization of the mentally ill. We're finding that many of our jails and our prisons have become the places where our mentally ill are going when they don't have the support, they don't have the access to mental health on the outside. So what happened is that you had many psychiatric institutions that were providing care, and then a lot of legislation went through that started to bring more of the mentally ill individuals into the community. But then there was a reduction in the resources that were available. So we did not have those community-based initiatives at the level that we had them before. And so this is when you started seeing people becoming more incarcerated. So when you look at the hyphenated line, you see that that's our prison and jail rate and how that has increased. But then when you look at the mental hospitalization rate, that actually decreased. We know that only 20% of our care that we provide as physicians is making an impact on individuals' health, but it's more of the social determinants of health. Only 10% is the physical environment, 30% is behavioral health. And this is why we need to make sure that we are creating true collaborations to try to find the solutions. I love this terminology of social determinants of resiliency. We normally talk about the social determinants of health. However, I want us to make a shift where we're thinking about the resiliency, because this brings the mental aspect. And resiliency is somebody's ability to bounce back from trauma, bounce back from situations that have impacted their life. And that's what our individuals that are going through the reentry process are experiencing. And if their economic stability is not present, their ability to have access to healthcare or food security is an issue, it really reduces that person's ability to experience that entire Maslow hierarchy of getting to a place of self-actualization. In Springfield, we recently did a community health needs assessment, and our 4 top areas that we're focusing on are substance use disorder, homelessness, mental health, and also management of chronic diseases. I think it's important when we are doing community health needs assessments that we're looking at it disaggregated based upon individuals who have been incarcerated and those that are also going through the reentry process, because some of the drivers that we're seeing are actually from the experiences that people have had during incarceration. So when we think about incarceration, the United States is one of the top areas of incarceration, but Illinois is extremely high as well. It's at 433 per 100,000 in the population. When we're looking at health needs assessments of individuals who have been incarcerated, it's important that we're looking at the chronic diseases, whether or not they have had access to screening, whether or not they've been screened for HIV, mental health, hepatitis, whether or not they have experienced trauma, looking at the adverse childhood experiences, their social determinants of health, medications, whether or not they had those when they were incarcerated, but also do they have access to them when they've been released. Most places in Illinois provide between 2 weeks and 30 days of medication. Also, there has been a shift to making sure that the last 90 days of a person's incarceration, that they are starting to work more on that reentry process to make sure that there's a smooth transition. I also think that looking at the trauma history of someone prior to coming into prisons and jails is important, but also asking about the trauma history while they have been incarcerated. The school to prison pipeline is one of the places where I think that we need to start working more within our school districts, because we're finding that there's a disturbing national trend where children are being funneled out of public schools into the juvenile and criminal justice system. When you think about it, 40% of students expelled from the United States schools each year are African American. 70% of students involved in school arrest or referred to law enforcement are African American or Latino. When we think about the suspension rates, that is also impacting individuals that are being incarcerated. And we know that the foster care system is another place that's funneling in children. And so I think that when we're looking at data, it's important that we are trying to bring all the data together from all of these different systems so that we can truly see how individuals, one, can remain out of being incarcerated, but also trying to understand what are the systems that are driving the prison pipeline. Social determinants of resiliency, we talked about a little bit earlier, but I think when we disaggregate these, it allows us to come up with where are some of the solutions that we can have. So when we think about economic stability, it's about employment, but it's also about financial literacy. Does a person have a safety net? Do they have access to resources when they are in challenging situations? I know that Chicago has been using the 211 number, the hotline, which has been used, which has really allowed individuals to get access to jobs, access to different resources. When we think about the neighborhoods individuals are going back into, we talked about those 5 high zip codes in Chicago. Is there an opportunity for us to go back and look at food deserts in those areas? Are we releasing people and they're going out into places where they're not able to get housing or transportation is a challenge? Segregation index was something that we recently in Springfield have been looking at more. And what we have found is that whenever there's a higher level of a segregation index, and Chicago and Springfield have very high ones, this is areas that were redlined historically that have moved into areas that have these higher segregation indexes. These are some of the same areas where we're seeing higher levels of incarceration, higher levels of some of the comorbidities that we have been tracking. When we think about education, I think that one area that we could really start focusing more on is vocational training and whether our prisons are providing vocational training, but also are our students getting access to higher education? And then in the school district, are we starting to focus on initiatives that look at health literacy and pathway programs? These are opportunities for individuals to gain more education prior to being incarcerated. So the social determinants of health, basically to wrap things up, I think that it's important for us to assess a person's housing, education, and economics and food security. Also, when we think about the incarcerated environment, there is profound overcrowding. There's been a great level of documentation about sexual victimization. The use of solitary confinement is a problem. Standards of medical care, the NCCHC has a large resource that can provide individuals to understand what the standards of medical care are in correctional environments. And this is a place where advocacy can be placed, but also looking at the food choices that are available and even reduced movement. So we know that even when you're on the outside, if you're experiencing loneliness, that has now been equated to individuals smoking 15 cigarettes a day. So you can imagine in solitary confinement in Illinois, this has been reduced greatly. However, individuals are still being placed in solitary confinement. And this is a problem when people are released and getting them acclimated back into the society on the outside. The University of Illinois has recently produced a resource called Mapping Your Future and a Guide to Successful Reentry. And one of the things I really like about this is that it uses the stories of individuals who have been incarcerated and have gone through the reentry process to make sure that people are aware of the free clinics in Illinois that are available, to understand the health insurance practice, understanding how you can get back on Medicaid and Medicare when you are released from prison, looking at what dental and vision care is available, and even the pharmacy and access to medication. The Justice Involved Life Cycle has multiple points and opportunities to connect individuals to Medicaid coverage and care. It's important to remember that the wait time and enrollment sometimes can delay the process 45 to 90 days. So if you follow this diagram, individuals that enter the criminal justice system, some of them were on Medicaid or Medicare prior to that. However, when they are incarcerated, they're no longer able to remain on that. So there's a reclassification of their Medicaid coverage. So one of the areas that we have found really improves individuals' access is in the 90 days prior to being released, to really start that reentry process with insurance. I truly believe that the reentry process needs to start the day somebody becomes incarcerated, and looking at what social support that they can have while they're incarcerated, but also what they'll have on the outside. So there is an opportunity for us to improve the enrollment of individuals when they are discharged, but also to develop care coordination plans. We have also found that community health workers who have had the lived experience of being incarcerated is another point where individuals can really build that trust. But there's many programs, especially in Camden, New Jersey, where they had the community health workers to actually go into the prisons and the jails and to start working with individuals so that when they were actually released, they were still working with the same individuals. This helps with that transition of care. Health literacy among the formerly incarcerated population is an area that I think that we could pay closer attention to. We know that health literacy is one of the newest vital signs that we need to be assessing. And what we have found is that those who have been incarcerated or returning citizens, only 30 to 40% of them do not have a high school diploma. And there is sometimes a very low health literacy and limited educational opportunities. So this could be an initiative of really trying to focus on health literacy inside of the prisons and the jails. And this is a captive audience where they could be learning about their chronic diseases, understanding what they need to be screened on while they're in prison, but then also when they're released. Because whatever is happening inside of the prisons, when people are released, if we're not addressing it, that's coming back into the communities. And it has been said before that there's a revolving door. So if somebody is coming from an incarcerated environment, they're coming back to their family, this could be an opportunity for diseases to be transmitted. And so it's important for us to be the ones that are providing that screening opportunity so that our community is truly protected when they're being released. When we think about where are individuals going when they are released, 50 to 7% of them are going back into the home, but 20 to 30% of them are going into transitional housing and emergency shelter. Some of them are going in with friends and relatives, but about 10 to 25% of people who are being released from prisons and jails are entering into the unhoused population. I wanted to go through a couple more statistics that I think have been helpful for us to look at positive experiences that people have had when they have been incarcerated. And these we talk a lot about hot spotting, but there's also an opportunity for us to think about bright spotting, looking at the lived experiences of individuals who have gone through turmoil and really hard situations, but they were able to persevere and to continue to move through and become more resilient. So what we have found is that if an individual who is incarcerated earns a bachelor's degree while they're incarcerated, the recidivism rates actually drop 5 to 6%. Nearly 650,000 people are released from prisons annually. However, many of them are not able to access jobs. When you think about it, many employees have the box that needs to be checked whether or not you have been incarcerated, and this creates an immediate stigma for individuals. And so they have done research previously that have shown if you can remove that checking the box, if somebody has been incarcerated, and not enter that until after someone has gone through the interview process, that actually increases a person's opportunity to become employed. 25% of formerly incarcerated people lack high school diploma or GED. So trying to encourage people to obtain that while they're incarcerated or when they're released is another opportunity for us to improve the experiences that people are having. The Prison Policy Initiative actually showed that about 65% of formerly incarcerated people are still not able to obtain a job. So the impact of that economically is profound. On the right side, you see that when somebody has been formerly incarcerated, they might make $269 a weekly earning. However, in the general population, it might be about $507. So it's very hard for someone who's been released to be able to provide economically for their family. And so us trying to look at initiatives that increase a person's job and to look at some of the statistics of what people are getting paid can improve. So when we think about the preparation for the reentry process, I think that there are some key areas that we could focus on when people are incarcerated, and that's looking at life skills, vocational training, obtaining a GED, looking at mental health and substance use counseling, providing exit interviews allows us also to gain some of that critical data that's important to understand when a person is being released. In Illinois, the House recently passed a bill that makes sure that individuals that are leaving prisons and jails have access to naloxone. And what we have found is that formerly incarcerated people are 40 to 129 more times likely to die of an overdose in the 2 weeks post-release into the general population. We found that sometimes treatment is being disrupted. And then also there are bills that are being passed to make sure we have more individuals that are receiving MAT while they're incarcerated. And that's medically assisted treatment for substance use disorder. I wanted to bring to your attention that not everybody who is incarcerated has actually done a crime. And I want to bring attention to the Innocent Project. And the Innocent Project works with individuals who have been incarcerated to make sure that they are released. And I thought this was a quote that we need that reminds us that when somebody is incarcerated, it's not just them that's being incarcerated, it's that entire family. These are individuals who have mothers, they have children. And when you look at the impact of an individual that's incarcerated, I think that we really need to be paying attention to that entire family in the community. So for those of us that are taking care of patients, when we're seeing increased depression rates in our patients in the pediatric population or in adults, this is one area that people sometimes are missing, that an individual is dealing with someone that's very close to them that has been incarcerated. So we need to make sure that we're actually asking those questions. So what are hospitals' contribution to the reentry process? There has been some information on comprehensive education that and the acronym has been used around SHARE. When individuals come into the hospitals, we still want to make sure that a person is having autonomy, that they have respect, that they have empathy, and that we are also focusing on safety. And I think when you go back and look at how many people have had exposure to the population that has been incarcerated, it's very small. So looking at whether or not we have standardized checklists of whether or not people are being treated appropriately, or even having a reentry program team inside of the hospitals. In Camden, New Jersey, one of the things that they did is they looked at data that allowed individuals to connect with the prison population, but then also to connect with hospitalization data. And when they took that data and combined them, they start to find that there are super utilizers that have been incarcerated multiple times, and they have also had multiple hospitalizations. So then they started to focus on the top 5% of those utilizers. And what they found is that providing transitional clinic care, providing community health workers, they were really able to reduce the utilization of hospitals and also to reduce the arrest. That's one of the models I think that we should look at. Camden, New Jersey, Milwaukee also has another powerful model for us to take a look at. We have found that our medical schools are starting to focus more on medical humanities, and this is another entryway for people to start learning about the lived experience of those that have been incarcerated. This piece of art was called The Unbroken by Bars, and this is something that really helps individuals to understand the resiliency that individuals who have been incarcerated have to be able to go through the reentry process and really be successful. Dr. Ginsberg is a pediatrician who focused on individuals who were teens that were unhoused. And he found that if they had these 6 qualities available to them, they were able to become productive members of society. And he found that if they had social support, that they had mental health education and mental health support, that they had true consistent connections. And this is why we need our community to make sure that they're proximate to individuals, because the more you're connected, then that builds up that resiliency, that there was environmental stability, they had positive relationships with healthcare, and that they had the ability to cope. These were the areas that allowed these teens to be able to move in a positive manner. What we have found is that it's these same support systems with individuals that have experienced incarceration that can make a difference. In medicine, we have started to do more screening around the social determinants of health. And I just wanted to share with you all some of the surveys that are being used, that hopefully when individuals are going through the reentry process and they're coming back into our clinics, that we're using these. And the ones that I really like are from NASM, Prepare, and then also the WeCare screening tools. I also believe that if we are screening individuals, then we need to make sure that they have access. If we're screening and we don't have the support systems and resources for them to be able to connect to, this can be another area that reduces trust. I have always had the opportunity to work in federally qualified healthcare centers, and that's one of the areas that I really enjoy, having the support systems of our community health workers, the support systems where we know where the resources are for individuals, that we're able to connect them. And I think that the more we're able to do that systemically, it can really help individuals. We have also found that individuals that are able to experience transitional care clinics, the reduction of hospitalizations happen, and then also the reduction of problems with parole. That happens with people using the transitional care clinics as well. For our individuals that are part of the Institute of Medicine that are focused on policy, I wanted to bring up a couple of areas that can really make a difference around community initiatives with policy. One, having access to mental health care inside of the prison. I think that using telehealth care and advocating for that can really improve the health care of those that are incarcerated. Also, integrating mental health care inside primary care centers. Looking at mental health literacy among school-based clinics. Workplace mental health policies can make a difference, and definitely focused on criminal justice reform. I know that there has been recent policy that has been passed that is even looking at how individuals are going into segregation because we know the mental health effect that this has. And so now quarterly, the Illinois Department of Corrections has to release a report that tells us how many people are in segregation. Also, policy that really improves the amount of affordable housing that is outside of the communities. Since we know that many individuals that have been incarcerated have mental health issues, it's very important that our psychiatrists are being involved in advocacy, looking at crisis intervention and support services, community education, and always doing a holistic view of our patients. I want to bring up the work of Marian Wright Edelman. And Marian Wright Edelman talks about in the Children's Defense Fund that there is a cradle to prison pipeline. I remember when I first started doing work in correctional medicine, this surprised me when I realized that healthcare is one of the feeders into the cradle to prison pipeline. Poverty is a feeder into this pipeline, the justice system, healthcare, and also education. So I wanted to disaggregate how this contributes to the prison pipeline. So as far as poverty is concerned, when children are disconnected, they're disadvantaged and neglected because some of the drivers of poverty, this ends up being one of those fast ways that individuals are being incarcerated. When you look at healthcare, if we in the medical field are not providing access, we're not providing the prevention that's needed as far as mental health is concerned, or somebody receiving the psychiatric support that they need, or looking at the education and the support, then healthcare, we are one of those drivers for this pipeline as well. We see that the legal system, the zero tolerance disciplinary, the criminalization of poverty, the criminalization of individuals who are unhoused sometimes, that this can be a driver as well. And then also looking at the criminal justice system. Some of the neighborhoods are over-policed, or looking at what are ways that we can reduce recidivism or incarceration. In Springfield, one of the things that our police force has started to do is now we're able to have mental health individuals to go out with the police if it is a call for someone who is in distress mentally. And that has started to reduce the numbers of individuals who are getting incarcerated, because police officers, they have been trained in many areas. However, if they have that mental health provider that's with them, then that ability to support that person and to also make sure that they're getting into the right system, the psychiatric healthcare systems versus a incarcerated environment, is critical. I want to spend a little bit of time talking about our pediatric population, because we tend to think about adults, but our pediatric population has been impacted by incarceration. We have children who have parents that are incarcerated. We also have babies that are born while the mother is incarcerated. We also have children that are inside of the juvenile justice system. And I thought these statistics were critical, because when you think about a person who has been incarcerated, many people say that, and actually 67% of them have been handcuffed in front of their children. You can imagine the trauma that they have experienced from that. Or 57% might have PTSD if they have witnessed an arrest. 27% of children report that they saw weapons drawn. And so even looking at initiatives that allow children to be removed from environments, sometimes it cannot happen, but sometimes we can reduce this, and this reduces some of that harm. There's been a bill that's recently been passed, and actually not recently, it was back in 2015, SB 100, and this started to make a difference, which eliminated the zero tolerance policy inside of schools, which looked at suspension rates, expulsions. Schools were now required to have parent-teacher advisory committees, so people became more proximate to the lived experience of individuals. And also there are school boards that are driving guidelines on the discipline to make sure that the school system is not one of these feeders into the prison population. Alternative programs are critical. We talk a lot about what reentry looks like, but how can we start focusing more on the programs that prevent individuals from going into prison and jail? And those diversion programs are important. Restorative justice, mentorship programs, family support systems. And on the right, I wanted to highlight one of the programs that we have in Springfield called The Outlet that focuses on boys who do not have fathers. And they are really working with the juvenile justice system to provide opportunities for boys so that they never have to enter into the incarcerated environment. Vera Institute of Justice, one of the areas that they were focusing on is really trying to look at the dignity of a person. The dignity of a person allows fairness to be applied, allows more transparency and data, and allows a person's morale and well-being to be looked at. And so that is one of the areas that I would like for you all to look at, the Vera Institute of Justice and also the Bureau Justice Assistance. And maybe when we do questions. So I just have a few more slides that I'd like to get through. And thank you for your patience for allowing me to come back on. So when we think about the cost of incarceration, adults, it costs about $45,828 each year for one person to be incarcerated. And this number is really low. This was from the Justice Center for the Council of State Government. When you look at youth, it's up to $85,000 per year. And when you think about if we could do something to reduce people from going in, or even to start to look at the recidivism, we could do a lot with those funds. And so we really need to make sure that our policymakers, our healthcare field, are coming together to try to figure out how we can move some of that funding.
So a question that we have here is, what is your experience with programs like the SAFER Foundation in reducing recidivism and helping previously incarcerated individuals to be successful in their transition back into life after incarceration?
Well, the SAFER Foundation, I think, is working more in Chicago than where I am in Springfield. However, it was one of the programs that I had listed that had positive results. And I think that a couple of other programs that exist are the transitional care clinics. It's important for us to embed those inside of the communities in those zip codes, and they're working very closely with the SAFER Foundation as well. Also, when we think about some of the best examples outside of Illinois, New York had a program called FUSE, which stands for Frequent User Services Enhancement Initiative. And what they did is they took the top super utilizers and they worked with 200 of these individuals that had the most complex involvement with multiple public sectors. And what they found, we're all working in silos, you know, and so that's one of the things with the Institute of Medicine, those silos are really breaking down. And what they found is that the more they can share the data around what services people are utilizing, then they were able to develop programming and initiatives similar to the SAFER Foundation and the transitional clinics that really make a difference.
I have a couple questions. What do you suggest our attendees and also other IOMC fellows, what do you suggest they do in order as a follow-up action? How can they participate? What difference can they make realistically? I mean, obviously you're very involved in this and have a lot of experience. So your words would carry a lot of weight as what other people can do.
Well, and right now, I have not worked inside of the prisons in a couple of years. And what I have found is being outside of the prison, we can still make a profound impact. And so I think the first one that I would think about is raising your own awareness. How can you, remember we talked about Brian Stevenson and becoming more proximate to individuals from marginalized communities. How many of you all have actually visited a prison, or have you watched any documentaries? Ava DuVernay has a powerful film documentary on Netflix called The 13th. And then you start to see the historical impact that prisons have had inside of communities. The other thing is looking at the social determinants of health. So those that are in medicine, are you actually coding for using the Z codes and the V codes? Because that data is going to be important for us to understand what our patients are experiencing. I think asking and screening for incarceration more for those that are working with the pediatric population. I've recently was with someone in clinic, and one of our residents came in and said that the child is with their grandmother. Just asking that simple question of where are the parents? And it turned out that child actually had parents that were incarcerated. So a lot of the behavior we were seeing was because of the trauma of being removed from the home and being placed in another environment. Working with individuals that are in the foster care system, creating transitional clinics, or transitional clinics inside of the clinic that you already have can be another opportunity to make a difference. So those are just a couple ones, but also looking at best practices around the United States to see what has worked. I loved when I heard about Norway. Norway has 20% recidivism. In our country, people stay 3 to 4 years on average. In Norway, it's 6 months. But there's been a huge shift in Norway that focuses on the dignity of that individual. They're not wearing prison wear, they're in their own clothes. People are greeted at the front door. Also in Philadelphia, they are starting to look at different models that exist in Germany for incarceration. A lot of people are not aware. In one of our electives, I'm not from Illinois, but when I moved here, we found out that there's a mom and baby program where the babies stay with their mother in prison up to, I believe, 18 to 36 months in Decatur. However, there are only 8 beds for that. And we actually did a tour and we visited that area and were able, it was just a different world with what they were able to do with the moms. Moms had individuals that were supporting them and helping them, and that they have found that moms and baby program actually reduces recidivism. So just raising the awareness about what people are experiencing. I know that Illinois was one of the first states that banned shackles for pregnant women. However, we know that this is still occurring because not everybody is aware that this is something that has been banned. So developing programs inside of hospitals, so when the patients do come, that they are following the protocol that Illinois has worked so hard to establish. So those are just a few.
Mm-hmm. Okay. Can you share with us what areas of poor health exist mostly with the incarcerated individuals, or require, what diseases or require maintenance beyond incarceration itself?
Sure. I have an entire slide that I'm not able to get to, but I'm just going to give it to you by remote. So a couple of things that people have seen are really around chronic diseases. So high blood pressure, diabetes, asthma, some of the same things that we're seeing on the outside, but you can imagine in the incarcerated environment, there are barriers to healthcare. When you are incarcerated, to get into the doctor, you have to pay $5. And many people are not aware of that. And one of the things that when people are working, I think in Illinois, they make 9 cents an hour. And so that's equivalent to like a copay of $500 on the outside for that individual. So what we have seen is HIV is at higher rates, hepatitis C and B are at higher rates. So when I see someone who is coming to me who has been incarcerated, they have been screened in prison. However, it's very hard to get the information from prison. So one of the things I would love is for things to become more electronic. And I think that there are bills out there that say by 2027, things do have to become more electronic. And hopefully we do have that ability to talk with what people have experienced when they were incarcerated, because it's hard as a physician when you don't know the full history, and then you're dealing with individuals that have low health literacy. So many times they're not aware of what's going on. So STIs are extremely high. So I screen for gonorrhea, chlamydia, syphilis. I think that prevents the spread into the community. So those are some of the ones that are higher.
Mm-hmm. So, obviously over the years, for a long time now, coordination of care, integration of care is really important. So those who are about to leave prison and, enter the full community again, are they given referrals to doctors? Is there a group of doctors that work more with the inmates who are now becoming part of the community? How do they find, in other words, how do they find a physician who will be respectful and, also helpful to them, in ongoing treatment?
Sure. So the individuals who have been justice impacted in every prison and every jail, I feel like we have different things that are happening. So it's not for all of them. But one of the things that we have found is that there are programs where community health workers are coming into the prison. There has been a seamless transition, and they have found that when individuals are able to get that support on the inside, that they're able to get Medicaid. So Chicago has multiple transition care clinics that are available to individuals. There are many foundations like the Safer Foundation that provides that continuity and support for individuals as well. And then also the city of Chicago has an entire reentry program. So that's where we're seeing the 211 number being utilized for someone who's coming out. So when you think about it, trying to coordinate all of the care that they need, from housing, food insecurity, healthcare, having one place to go makes a huge difference for them.
Mm-hmm. Yeah, that makes sense. It makes sense. Good. Well, I don't see any other questions at this time. So I thank you very much for your presentation. A lot of good details. For those who have attended, the PowerPoint and the video will be available in about 30 days on the IOMC website. And, certainly be able to free to do that. If you want to get in contact with our speaker, please feel free to contact the IOMC office by email, and we'll be glad to send your email on, to Dr. Elamine so that she can, be in contact with you directly. And I also want to give just a couple of reminders. We have some programs that are coming up in April, and then also our big event on June 26th, 25th, on 2026 for the 2026 Leadership Awards and annual meeting. So thank you again, Doctor, for all of your efforts, all of your information. This has been very rich, very robust, and we appreciate the fact that you are highly involved in this and making a difference. I know that you've won many awards for your work in this particular area. Greatly appreciated by all. Thank you.
Well, thank you for this opportunity, and I'll make sure that my slides are available. I apologize that I've had some technical problems, but thank you very much for this opportunity.
No problem. Things do happen, but we persevered. Our own example of resilience getting through this.
Yes.
So thank you everyone for joining us today. If you would like any other information, please feel free to contact IOMC. If you are not a fellow of IOMC and you'd like to become one, please contact the IOMC office. We'll be glad to talk with you. Have a good day and a remainder of the week. Take care.